Gastrointestinal bleeding. Okay, gastrointestinal bleeding can be very profuse or it can be very, very mild. Like for instance, with worms, what will happen? Worms such as hookworms will be in the duodenum and they will get into they will bite into the mucosa of the duodenum and drain the blood very slowly. Or if there is an ulcer in the stomach or in the duodenum, that can also drain very slowly. Excuse me. Excuse me. Excuse me. Um, so it can be very slow, and so the person will present with anemia, and so the thing can so it can be done over a period of time. It can be managed over a period of time. Whereas profuse gastrointestinal bleeding with the rupture of an artery or with the rupture of a vessel, or even with duodenal and gastric ulcers, may be very profuse and may require emergency treatment. Okay. Now, if there is if the person has gastrointestinal bleeding, the blood can come out in two ways. One, it can come out of the mouth or it can come out of the anal orifice. If it comes out of the mouth, that is, if it is vomiting, if the person is vomiting blood, then it is called hematemesis. Is blood and emesis is vomiting. So hematemesis, vomiting blood. Then if it comes out in the stools, it can come out either as hematochezia or melena. Melena means black, tarry, foul-smelling stools. That is because of the bleeding has taken place in the upper GI tract and it has been degraded by by the digestive juices, and it is coming out like black, tarry material from the anus. This is called melena. Or hematochezia, if it is blood in the rectum or in the colon, or even in the GI tract, when it is transmitted very fast outside, it will come out as blood or blood mixed with stools. That is called hematochezia. What we call upper GI bleeding is any bleeding above that is from the esophagus, stomach, or duodenum. Below the duodenojejunal junction, which is the ligament of Treves, it is called lower GI bleed. Upper GI bleed is above the ligament of Treves, which is in the fourth part of the duodenum. Okay. Obscure GI bleed, that is, there is bleeding from the GI tract, which you can see, which is seen, but there is bleeding, but it is not shown in an upper or lower GI endoscopy, where we put the endoscope through the mouth or through the anus and have a look. It is not shown at all. That is called obscure. Occult GI bleed, that is, you identify the blood in the stools, but it is in the but only by microscopy. There is no bleeding seen. You send the stools for a routine check and you find some blood cells in that. That is called occult. Occult means you cannot see it. Causes of gastrointestinal bleeding: there's upper gastrointestinal bleeding, lower GI bleeding, obscure GI bleeding, or occult GI bleeding. That we showed you in the previous slide. I'm just giving it to you in a quick way. Okay. Now, upper gastrointestinal bleeding can be a peptic ulcer. In your second year, you would have learned about peptic ulcers. Esophageal varices bleeding, that is the varicose veins in the esophagus. Okay. Portal hypertension gastropathy. Portal hypertension gastropathy can lead to esophageal varices and you can get this bleeding. Mallory-Weiss tear. That means if you vomit very violently, if the patient vomits very violently, there can be a tear in the mucosa of the gastrointestinal tract at the junction of the esophagus and the stomach. There it can produce a tear in the esophagus, the lower end of the esophagus, and that can cause some bleeding. Arteriovenous malformations can cause bleedings in the gastrointestinal tract. Esophagitis or esophageal erosion, either because of hyperacidity or because of Zollinger-Ellison syndrome, and you can get esophageal erosion and it can cause bleeding. Duodenitis, gastritis, erosions can all cause upper GI bleeding. Aortoduodenal fistula, this is very rare. The duodenum, there may be a duodenal ulcer which ruptures externally. When it ruptures, the structure behind the duodenum is the aorta. The aorta, the inferior vena cava, all these travel behind the duodenum. So that can rupture, the duodenal ulcer can rupture into the aorta, and that can cause an aortoduodenal fistula, and the person will be bleeding directly from the aorta into the GI tract. Duolophoid lesion, this is an abnormally large artery lining the gastrointestinal system. This is very rare, and if this is there and if it is eroded, it can cause upper gastrointestinal bleeding. Lower gastrointestinal bleeding can be caused, that is below the ligament of Treitz. This can be caused by hemorrhoids, which we commonly call piles. Diverticular disease, these are little diverticuli, like little diversions of mucosa seen in the colon, and that disease can cause inflammatory bowel disease. There are many inflammatory bowel diseases like Crohn's disease, ulcerative colitis, celiac disease. So these are inflammatory bowel diseases, and they can cause bleeding of the lower GI tract. Vascular ectasia, abnormal vessels, just like this Duolophoid syndrome. You can have vascular ectasia, you can have a growth of abnormal vessels in the gastrointestinal tract which can rupture and cause a bleed. Neoplasm means tumors in the GI tract. Ischemic or radiation colitis, because of certain diseases, we might give radiation to the abdomen, you might give radiation to the pelvis, you might give radiation to the pubis, say for carcinoma of the cervix, and because of that radiation there can be some problems with the vessels, so it becomes ischemic. The vessels, that there's a lot of fibrosis, so there will be very little bleeding there, and so because of that there can be colitis, and the colitis will cause a rupture of the existing vessels, and there you can have bleeding. Colonic ulceration, just like ulcerative colitis, and you can have colonic ulceration because of carcinoma of the colon, and so all this can cause lower gastrointestinal bleeding. Obscure upper geoendoscopy and colonoscopy is negative. They've not found the cause of the bleeding, but there is obviously some bleeding because we have seen it we have seen it either in the stools or the patient has been vomiting. Because of this, we might put a tube, because they vomit or because they pass blood in the stools, we might want to investigate with upper and GI endoscopy, and even then we may not be able to see the bleeding. That means obscure GI bleeding. That could be because of small bowel vascular ectasia, small bowel adenocarcinoma, that is jejunum ileum adenocarcinoma, or jejunum ileum stomal tumors. That is, stomal tumors are when you repair, when surgery has been done, and at the surgical site where you have sutured, there can be some bleeding. Meckel's diverticulum. This is a diverticulum of the ileum to the umbilicus. Okay, so there can be Meckel's diverticulum, and this is a diverticulum which can be either a band or a diverticulum itself of the duodenum, which is tied up to this is a remnant of the infolding of the endoderm. The endoderm is infolded, but while the endoderm was infolded in the embryo, the closure of the diverticulum was not complete. The closure of the connection with the umbilicus was not complete, and therefore you can have a diverticulum there. Ectopic varices, varicose veins in the wrong places. Hemobilia, bleeding from the biliary tract, from the common hepatic duct or the hepatic duct. So from the liver, if there is any bleed, it will come through the bile ducts, and from the bile ducts it may come out into the duodenum, and from there come. So this may be one of the causes of obscure GI bleeding. Aortoenteric fistulae, that we already showed, the aortic aortoduodenal fistula is one of the causes of upper GI bleed. This can be This may not be seen on endoscopy, and so it is called a obscure GI bleeding. Occult GI bleeding. While examining the fecal material under a microscope, you may see some blood cells. You don't know where it's coming from. Usually, it can come from any cancer in the stomach, or in the duodenum, or in the intestines, or in the colon. It can be from there, little by little, or it can be because of worms. That is, it can be because of, say, Ankylostoma duodenale, that is, hookworm. Crohn's disease, vascular ectasia, duofoil lesion, worm infestation, I've already said. Gastrointestinal ulcer at any site, maybe because of typhoid. The Peyer's patches in the ileum may be inflamed, and there they can rupture and cause some bleeding. So typhoid can be a cause of occult GI bleed. Portal hypertension, gastropathy or colonopathy. So when we pass colopathy. So when we pass endoscope, either upper GI endoscope or a colonoscope, we still have not located the thing, means then it is obscure. Occult, the blood is seen in the stools, but the cause of it is not known. It is not seen. So that is occult GI bleeding. Okay, so whenever we have bleeding from the GI tract, we should have an assessment. The patient should be admitted in the ICU. Because the patient is bleeding, they may go into shock. So we have to identify this first. We have to start an IV line. We have to start giving blood transfusion. Urine output should be monitored. If the blood volume is adequate and if the blood pressure is adequate, the patient will pass urine normally. But if the blood volume is inadequate and the patient's hemodynamic status is low and the patient is in shock, then they will not be passing urine. So the urine output has to be monitored. Oxygen has to be supplemented, because all the hemoglobin should have, there will be very little hemoglobin, and all of it should be saturated with oxygen so that it can give enough oxygen to the blood, to the brain. Okay. The history. Once they are admitted, they are stabilized, we get the history. How are they losing the blood? Are they vomiting the blood, or are they passing black tarry stools, or is there profuse bleeding from the rectum? Then we should look for any symptoms of abdominal pain. Abdominal pain means it must be a peptic ulcer or upper GI ischemia. Symptoms of liver decompression, like they may have ascites, they may be jaundiced, encephalopathy with esophageal varices. Then we will know that it is hepatic jaundice and they are liver decompensation, and therefore they are having bleeding from the GI tract. Okay. The other history that we should take, are they taking non-steroid anti-inflammatory drugs? All non-steroid anti-inflammatory drugs like Zerodol, diclofenac sodium, diclofenac potassium, Voveran, Brufen, Combiflam, all these drugs, paracetamol, aspirin, can all cause gastrointestinal erosion, and therefore they can cause bleeding. Suppose the person has been vomiting a lot and has been retching, then they can get a Mallory V stare at the esophagogastric junction, and that can cause bleeding. Is there a history of dizziness, headache, decreased urinal output? Is the person feeling faint when they sit up? All these should be taken in. Then we should look for past history of similar episodes. In the past, have they had such problems before? Are they consuming alcohol? Is the person smoking? Smoking can cause ischemia. Ischemia can cause fibrosis, and because of the fibrosis, there can be less blood supply, and so there can be small areas of patchy gangrene, ulceration, and therefore they can have bleeding. Alcohol consumption will cause liver failure, and because of liver failure, they can have bleeding. Then we should examine them. We should look for whether the mouth is dry, whether they are pale, whether the extremities are cold, whether the blood pressure is okay, and how is the pulse. We should look for jaundice, ascites. Ascites is fluid in the abdominal cavity. Whether that is there, any signs of cirrhosis liver, We should look for other places where they are bleeding. Suppose they are bleeding under the skin, whether if they have purpuric patches or ecchymotic patches under the skin, we know that there may be such patches in the gastrointestinal tract also, and therefore they are bleeding from within the gastrointestinal tract. We should do a thorough abdominal examination. We should palpate the abdomen, see if there is tenderness, whether there is any nodule in the umbilicus. An umbilical nodule will indicate carcinoma. Okay, in the GI tract, whether there's any abdominal mass, whether there's any cancer, whether then we should do a rectal examination to see if there are hemorrhoids, whether there is a tumor in the rectum, or whether there's a fissure in ano or fistula in ano. And then we should do a vaginal examination, rectal examination for pelvic deposits. Okay, in the vaginal examination and rectal examination, we'll feel whether there are any nodules in the pelvis, whether there's any mass in the pelvis, which can come from anywhere as seeding, as secondaries from a primary gastrointestinal tumor. Then we look for whether then we should also look for variceal bleeding or non-variceal bleeding from the gastrointestinal tract. So there we should look, if that is the bleeding, if they are vomiting blood, then this could be the cause. And so we must look for all the blood tests, look for creatinine, look for liver function, do an esophagoscopy, gastroscopy and duodenoscopy. If the bleeding is not from the varices, then they should be given these H2 receptor antagonists, like say ranitidine, or proton pumps like pantoprazole, proton pump inhibitors, somatostatin, prostaglandins to improve the clot stability. Okay, we can do endoscopic injections to cause vasoconstriction, or we can give sclerosants to cause some amount of fibrosis so the vessels are not bleeding. We can do we can inject a thrombin fibrinogen mixture so that fibrin is formed and it will cause a clot. Endoscopic thermal therapy such as bipolar electrocautery can be done, or cryotherapy with cold can be done. Then we can use endo loops or hemoclips, which can be used to clip the blood vessels that are bleeding. Or we can even do endoscopic suturing of the vessels so that there's no bleed. Management of variceal bleeding. If it is varices, if it is the previous things that I told you, we could do for, say, a duodenal ulcer or a gastric ulcer. But if it is bleeding from the esophageal varices, we must give vasopressins, stomatostatin, endoscopic sclerotherapy, or band ligation of the varicose veins, or you can do a transjugular intrahepatic portosystemic shunts, okay, inside the liver, so that the pressure becomes less in the varicose veins in the esophagus, and so they won't form esophageal varices, they won't dilate and form esophageal varices, so that we can shunt the blood away from the portal circulation into the systemic circulation. Or we can do systemic portosystemic shunt, that is surgical, or balloon tamponade with a Sengstaken-Blakemore tube. I'll show you this. Here you see different ways of shunting the blood. See, you are seeing the portal circulation, and in the red color the portal circulation is shown in blue color, and the systemic circulation is shown in the maroon color. So in the first picture you are shown both separately. In the second picture you can see that the portal vein has been sutured to the inferior vena cava. Okay, or here you can see the portal vein, that is, there it is. In the second picture you can see that it is sutured side to side. In the third picture you can see it is sutured end to side. The portal vein is sutured into the inferior vena cava. In the fifth picture, you can see that the inferior vena cava is sutured to the portal vein, to the intestinal veins, so that the intestinal veins drain directly into the esophagus, whereas I'm saying esophagus, into the inferior vena cava. But this is not a very desirable operation, because you're cutting the inferior vena cava off, and so the blood from the legs will not go into the systemic circulation. It is not a very good surgery, but of course the peripheral circulation will take care of it, but not adequately. It will lead to a lot of other problems. Then the splenic vein, the proximal portion, is sutured into the renal vein, or the last picture, the distal part of the splenic vein is sutured to the renal vein. This will cause all the blood to go from the gastrointestinal tract to go directly into the systemic circulation. So the portosystemic shunts will bypass the liver, because the liver is damaged, or because there is cirrhosis of the liver, or there is tumor in the liver. What will happen is all the portal blood that is from the intestines will go directly into the systemic circulation. The problem about this is it will definitely stop the bleeding, but the problem about this is all the toxins will get into the systemic circulation. They will go to the brain, and they will cause a hepatic coma. Okay, because the blood is not going to the liver, it is going directly into the systemic circulation. It can go to the heart, it will go to the brain, and so the person will be jaundiced. Okay, so here, this is the thing that I wanted to show you. There is a shunt, intrahepatic shunt. You can see the shunt vessel. It is sutured from one of the branches of the portal vein into one of the branches of the hepatic vein. This is the Sengstaken-Blakemore tube. Okay, this part of the tube is used to, pardon me, I will go to the previous slide again. There you will see that this part of the tube is used to aspirate the stomach contents. All the blood in the stomach, all the contents of the stomach will be aspirated. This part will be inside the stomach. This part will be in the esophagus. Okay, so first of all, we will pass the tube into the stomach nicely and inflate this one, and then pull it out. When we pull it out, it won't come into the esophagus. Then we will inflate this. This will squeeze all the esophageal varices and will prevent bleeding. Okay, so here you see how we pass the tube through the nose, through the like a nasogastric tube, because here it is bleeding in the esophagus. Here you can see that it is bleeding. The esophageal it is bleeding from the varicose veins here. So now when we pass the tube inside, this one will go into the stomach. We will inflate it so that it won't come out, and then we will inflate the esophageal thing. Once this is inflated, what will happen? This will press on the esophageal varices. It will press on the esophagus veins, and it will stop the bleeding. Whatever blood has already bled into the stomach, that we will aspirate using the okay. Okay, so this is the way it will be passed, and this is the way it will be kept, so that there is no bleeding from the stomach, from the esophageal varices. So this is a Sengstaken-Blakemore tube. And then slowly what we will do, we will deflate the balloons. We will deflate the balloons little by little and aspirate and see. If there is no bleeding, we'll take out the tube. If there is bleeding, we'll have to continue with the Sengstaken-Blakemore tube. Prevention of recurrent variceal bleeding. We'll arrest the variceal bleeding, but after that we have to give all these drugs to reduce the blood pressure, so that the pressure is less, and so there is no dilatation of the varicose veins. Okay, we can also do endoscopically, we can do ligation of the varicose veins, or we can do the shunt procedures that I talked about, that is from the portal circulation to the systemic circulation. Now we'll come to lower gastrointestinal bleeding. Lower gastrointestinal bleeding, first of all, usual cause will be rectal varicose veins. Okay, we call them hemorrhoids or piles. Okay, so we'll have to do a rectal examination, then we'll have to do a sigmoid colonic examination, then we have to do a colonoscopy to see where the bleeding is coming from. Bowel preparation is required, and best results are yielded with a prepared bowel. Prepared bowel means all the feces, there won't be any bowel contents. So then it will be easy to see only the bleeding and the digestive juices. Otherwise, feces will be there, food material will be there, and then we won't be able to see anything at all. Okay, so we can do either a limited preparation, that is, we can do any 20 to 30 minutes before the procedure, or we can do a full preparation. We can avoid high residual food for 24 hours, give a laxative, and then give an oral lavage. That is, they will have to drink about 5 liters of polyethyl glycerol mixed in water. And so then they will have continuous diarrhea for about 2 hours. And after that, the bowel will be actually clean. Okay. Other investigations that we can do are radionucleotide and scintigraphy. That is, you can give titanium 99, which is an isotope of titanium, and then this will be absorbed and will be taken up by the blood cells. And so when the blood cells are circulating, they will give them, and if there's any bleeding, you will be able to see it on a film, on fluoroscopy. You will be able to see the bleeding. You can take photographs of it. Okay, and then we'll be able to see this, and then we will know where to do the surgery. Okay, or we can do an angiography. When you do an angiography, when you inject a dye into the blood, that dye will be coming out from the bloodstream, and you can see the bleeding in the bowel. Then you will know that this is where it is bleeding, and there you can go and do something. Management of lower gastrointestinal bleeding. Like in the upper gastrointestinal bleeding, we said that we will use a Sengstaken-Blakemore tube, or we will do shunting, or we will do and we will give a lot of vasopressins, that we will give drugs that reduce the pressure, not vasopressins, but drugs that will reduce the blood pressure. Here in the lower gastrointestinal, we can do endotherapy using vasoconstrictors, we can do cauterization, okay, or we can do hemoclip and band ligation. This can be done for the upper GI endoscopy also, but here we will be doing it through the colonoscope. We can do angiography with intraarterial vasoconstrictor injection or microembolism. You go in through one of the femoral vessels, go into the aorta. From there you can get into one of the gastrointestinal vessels, and you can push material, small little things, small little articles in the blood, which can go and block up the vessels that are bleeding. Or we can do a surgical segmental resection of the bowel. Wherever the bleeding is taking place, we can do a resection of the bowel. Some obscure causes of GI bleeding: angiodysplasia of renal failure due to fluid overload, the reactive hyperemia following dialysis, hypokalemia, hypogastrinemia. Okay, all these can cause these are some obscure causes of bleeding. Gastric vascular antral ectasia, cave. It is characterized by tortuous vessels, dilated vessels in the gastric antrum. You know the stomach. The stomach is divided into body, fundus, antrum, pylorus. The antrum is just before the pylorus, where it exits into the duodenum. That is where most of the ulcers occur. Now, that's where the gastrin secretion takes place. So, gastric vascular antral ectasia, if it becomes very dilated, the vessels can become very tortuous, very dilated, and this is some obscure cause. It is nothing to be dealt upon. These are all very rare causes. Okay, thank you.